Hi class, and welcome to Module 4. We're in kind of our final push for the semester. We have about 4 chapters to get through in 3 weeks, so it's going to be a lot, but I've really tried to kind of condense these PowerPoints and really just focus on what I have highlighted and what I talk about in lecture. We'll have class tonight, which will be on kind of parts B and C. So I'm dividing chapter 21 into 2 parts. This will be part 1 of the respiratory system, which really reviews all the anatomy of the respiratory system. And then tonight in class, part 2 of chapter 21, we'll talk a little bit about respiratory function and how we can measure respiratory function and some of the diseases associated with the respiratory system. So there's a lot of slides to get through, but I include them because a lot of them are review for anatomy, and I'll skip over some of those, but I include them to give you guys a good base. So here we are. The main functions of your respiratory system is to supply your body with oxygen, which is needed for cellular respiration. And cellular respiration is the way your body takes in glucose or food and turns it into energy. And we need oxygen for the last step of that process. Your respiratory system also disposes of carbon dioxide, which is a waste product of that same process, cellular respiration. The respiratory and circulatory systems are closely coupled because the blood in our circulatory system will give us kind of the highway for oxygen to travel down. Your respiratory system also functions in your sense of smell and speech. And we divide the respiratory system into 4 processes. And I include this not necessarily because you'll be tested on it, but because I want you to learn kind of the language and the lingo of your respiratory system. So pulmonary ventilation is breathing, and this is the movement of air into and out of the lungs. External respiration is the exchange of oxygen and carbon dioxide between the lungs and the blood. And then in the circulatory system, we have the transport of oxygen and carbon dioxide in the blood. And internal respiration is the exchange of oxygen and carbon dioxide between your systemic blood vessels and tissues. So here we look at just how these 4 processes are combined and how the respiratory system is very closely connected to your circulatory system. Here are the main organs of your anatomy of the respiratory system, which you should review and you should know well. The differences between the upper respiratory system and the lower respiratory system, and kind of the division is your larynx or your voice box, or just right at the top of the larynx before we get into the voice box. You will be matching or identifying structures of a model that looks like this on your lecture exam. So again, here's your nasal cavity. The pharynx is your throat, and then the larynx is your voice box that air will go down into first before going down into the trachea and then dividing into primary bronchi to go to either lung. And then the primary bronchi will continue to branch into secondary, tertiary bronchi, eventually to alveoli, which is where the gas exchange will occur. So here are the structures of the upper respiratory system, their description and function. So use these as just a general review to review structures of the upper respiratory system and then to review structures of the lower respiratory system. So this is a good review just to kind of get your feet wet back in the game with all this anatomy of the respiratory system. So we'll go through upper respiratory system first. We have our nose, paranasal sinuses. Your nose is the only external portion. It provides an airway for respiration, moistens and warms the air, filters, cleans the air. It serves as a resonating chamber for speech, and it houses all your olfactory receptors that help you smell. We have the external nose and the nasal cavity. I won't ask you specifics about the external nose, but you can see it pictured and labeled there with the different cartilages that make up it. And then the nasal bone is the bridge of the nose, usually what people break if they're ever in a fight or in an accident. The nasal cavity is divided by the nasal septum. You have posterior nasal apertures or conae, where they're the openings where the nasal cavity turns into the nasopharynx, which is the throat behind the nasal cavity. The roof is formed by your ethmoid and sphenoid bones, and the floor is formed by the hard palate and soft palate above the mouth. Nasal vestibuli, you have nasal mucosa, the olfactory and respiratory mucosa, and then the nasal cavity itself and what makes up the nasal cavity. More in the conchae, we have superior, middle, and inferior conchae or concha, which are lateral projections on either side of the nasal cavity. These conchae just help to increase the mucosal area. So they're covered in mucus to help clean, moisten, humidify the air. And they also enhance air turbulence. So they allow the air to kind of come in and then spin to get it nice and clean and warm. The functions of the conchae are to filter heat, moisten the air. During exhalation, these structures will also reclaim the heat and moisture to try to keep the heat within the body and within the lungs. You have sinuses that we learned about a little bit. Well, you probably learned about them in anatomy. I'm talking about the spaces around the nasal cavity. They're spaces within your skull bones. They help to lighten the skull, secrete mucus, and also to help to warm and moisten the air. So here's a look at the nasal cavity. You can see some sinuses labeled there as well. The pharynx then is the funnel-shaped muscular tube. It's also known as the throat. You have three regions of the pharynx, the naso, oro, and laryngopharynx, which are shown there. And this is just the throat that air and food will pass through and kind of share the same pathway until food will travel posteriorly down the esophagus. We'll talk about the digestive system on Thursday, and air passes anteriorly down the trachea. So here's the nasopharynx, what makes up the nasopharynx with different tonsils and auditory tubes. Your auditory tubes come from your middle ear to help equalize pressure. The oropharynx is the passageway for food and air. It has different tonsils as well, and we'll talk about the oropharynx on Thursday. And then the laryngopharynx is food and air. It gives a passageway to the epiglottis. It extends to the larynx. And it's lined with stratified squamous epithelium. So here we have the pharynx, the larynx, and then the upper part of the trachea. One thing I should note here, the start of the larynx kind of starts with this cartilage, hyaline cartilage, which is called the epiglottis. It's a flap that will shut or close over the opening to the larynx when you do swallow food. So that food will travel down posteriorly down the esophagus. If the epiglottis doesn't close quick enough, something might go down the wrong pipe. So you might get some food or liquid in the upper part of the larynx, and you'll have to cough that out because it literally went down the wrong tube or the wrong pipe. But the epiglottis normally closes over the larynx to prevent any food and liquid going into the larynx to avoid a choking issue. You can have infected and swollen adenoids, which can block air passage to the nasopharynx, making breathing a little difficult. We won't go over that too much. So then we look into the lower respiratory system. So everything kind of below the epiglottis. So this makes up our larynx, trachea, bronchi, and lungs. The respiratory zone specifically is the site of gas exchange. So this will be your respiratory bronchioles, the alveolar ducts, and alveoli. And then the conducting zone is the conduit or passageway that transports gas to and from those gas exchange sites. So these will be kind of the passageways that bring carbon dioxide, oxygen to and from the respiratory bronchioles, alveolar ducts, and alveoli. The conducting zone will help to cleanse, warm, and humidify the air. So basic anatomy, we start with the larynx, which is your voice box. It provides a patent airway, meaning it's always open. It routes air and food into the proper channels, meaning when the epiglottis closes, food goes down your esophagus. When the epiglottis is open, air goes down your larynx. And we also have our vocal cords in your larynx. There's different cartilages, the thyroid cartilage, cricoid cartilage, and then we have paired cartilages, meaning there's two of them, as well as the epiglottis. The epiglottis, again, is elastic cartilage, not hyaline, excuse me. And again, it covers the laryngeal opening during swallowing. So here's a look from the external look of structures of the larynx. You can see that Adam's apple, the laryngeal prominence of your thyroid cartilage. It's always a lot easier to see in males because during puberty, testosterone not only lengthens the vocal cords of males, and that gives males their lower voice during puberty, but it also acts on your thyroid cartilage, males, to enlarge the laryngeal prominence. So males have a much more prominent Adam's apple. So here's a look at the larynx and the different cartilages that cover and surround the larynx to keep it open. The vocal folds, we have vocal ligaments, which are your true vocal cords. The glottis is the opening between the two. The folds will vibrate to produce sound as air rushes up from the lungs. The vestibular folds are false vocal folds or cords. They're not involved in sound production, and they just help to close the glottis during swallowing. Epithelium of the larynx is shown there. I won't ask you too many questions about epithelium of the larynx specifically. Here's a look at the photograph of all the cartilaginous pieces of the larynx. Again, the cartilage helps to keep it open and keep it very stable. A sagittal section of all the cartilages shown in the larynx as well. And this is a really neat look. So this is actually a laryngoscope, which you can put down someone's throat to take a look at their larynx. You're able to see the vocal folds closed and then open. And again, the glottis is the opening between the two. And they'll do this to check for infections, problems with the vocal folds, but it's kind of a cool picture to see this in real life. So how is voice produced? Speech will be intermittently released kind of bouts of air during the opening and closing of that glottis. The pitch of your voice is determined by the length and tension of your vocal cords. So the longer your vocal cords, the lower the pitch. So that's why males have longer vocal cords and the lower, deeper voice. The loudness depends upon how forcefully you push air through. You have chambers of the pharynx and oral, nasal, and sinus cavities that help to amplify and enhance sound quality. And sound is shaped into the language by the muscles of your pharynx, tongue, soft palate, and lips. And if any of you have speak a different language, you know that your tongue and the location of your tongue on the lips, the teeth, changes those sounds to become different letters and words. The vocal folds may act as a sphincter to prevent air passage. So for example, in the Valsalva's maneuver, the glottis will close. To prevent exhalation, the abdominal muscles will contract, intra-abdominal pressure rises, and this will help to empty the rectum or stabilize the trunk during heavy lifting. So when you're kind of bearing down, having a bowel movement or pushing out a baby, or you're lifting a 100-pound deadlift, this Valsalva's maneuver keeps your glottis closed to kind of keep pressure within the abdominal cavity to help kind of increase pressure below. Laryngitis, so we have an itis word, is inflammation of the vocal cords. It can result in dry air, overuse, tumors, or inhalation of something irritating. So then we'll get to the trachea. So below the larynx, we have your trachea extending from the larynx into the mediastinum. It divides into two major bronchi going to either lung. It's always held open by C-shaped cartilaginous rings. And you can feel those rings if you feel your throat. You kind of feel hard pieces. Those are C-shaped cartilaginous rings that are keeping your trachea open for good reason, to keep it open all the time so that air can pass through them. The wall of the trachea, you have a mucosa. The mucosa is lined with this very special type of epithelium called ciliated pseudostratified with goblet cells. The submucosa is the connective tissue with those C-shaped cartilaginous rings that prevent collapse. And then the adventitia is the outermost layer that just helps to kind of attach the trachea to the surrounding tissue. Trachealis is the smooth muscle that helps the muscle fibers contract. This contracts during coughing to try to expel excess mucus if anything was trapped. The carina is just the last piece of cartilage in the trachea, and it's the point where the trachea branches into the two bronchi leading into the lungs. The mucosa of the carina is very sensitive, and violent coughing will be triggered if anything foreign makes contact with it. So here's a look at the trachea. You can see this is showing the esophagus behind the trachea. The esophagus can kind of squeeze and become collapsible, but the trachea is always held open by these C-shaped hyaline cartilaginous rings. Here's a look at the epithelial layers of the trachea, the pseudostratified ciliated columnar. You can see not necessarily here, but you can see some goblet cells. Here's a goblet cell, and that's what secretes mucus to try to trap anything harmful that you might breathe in that gets to your trachea. The cilia kind of wave that mucus along to try to get that out of your trachea. So there is the epithelium of the trachea and the cilia shown in the trachea. I talk a lot about the epithelium because smoking will inhibit and actually destroy the cilia. And without ciliary activity, coughing is the only way to prevent mucus from accumulating in the lungs. So in the morning, smokers will develop this smoker's cough that tries to cough out that excess mucus because they've completely destroyed the cilia by smoking. If a person does stop smoking, there's good news. The ciliary function can recover within a few weeks. Tracheal obstruction is very life-threatening, so choking on anything, especially with small kids, grapes, popcorn, hot dogs. Many people have suffocated and died after choking on a piece of food that suddenly closed off their trachea. So just always take your time eating. I even heard of a man who was good friends of ours. He was just eating a steak dinner and a piece of meat got caught and he had to be rushed to the hospital and he almost died. So just make sure you're slowing down, chewing your food, cutting up your food for your kids. Things that are really preventable. Just be careful with what you eat and be careful what you give your kids. Make sure they're really small. The Heimlich maneuver is a procedure in which air in the victim's lungs is used to pop out or expel an obstructing piece of food. And if you know the Heimlich maneuver, you kind of put a fist right underneath where the diaphragm rib cage is, and you kind of just like force up into the rib cage with a double kind of fist. And what you're doing is you're using the victim's own air to pop out or expel what could be stuck or lodged in their trachea. And the maneuver is simple and easy to do, but it's usually best learned by doing a demonstration in real time. You can look up it on YouTube as well, because when done incorrectly, it could lead to cracked ribs. So I won't teach you how to do it here. The air passages then undergo about 23 orders of branching. So remember, we have one trachea coming down, it branches to each lung, and then those primary bronchi will completely branch into a place that looks like a huge tree as it goes to every single part of your lungs. From the tips of the bronchial tree, the conducting zone structures will give rise to your respiratory zone structures. So the conducting zone is only the part that conducts air, and then the respiratory zone is actually the portion of gas exchange. So this takes you through the conducting zone structures and how the trachea branch from primary bronchi to secondary bronchi, going to each of the lobes of the lung. If you remember from anatomy, you have 3 lobes on the right lung and 2 lobes on the left lung, because the left lung is smaller, because the heart kind of takes up some of that space. Then the tertiary bronchi are the segmental bronchi, and then those segmental bronchi will continually divide repeatedly. The branches become smaller and smaller until they're called bronchioles, which are less than 1 millimeter in diameter, and eventually they end in what we call terminal bronchioles, and this is kind of the last of the conducting zone structures. So here we have the branching of the trachea into primary bronchi, secondary bronchi, and tertiary bronchi, eventually ending in these terminal bronchioles. So here we have kind of the conducting zone, the supporting structures. Cartilage rings will become irregular plates and a lot less frequent. In the bronchioles, the tiniest ones, elastic fibers will replace cartilage. The epithelium will change and the amount of smooth muscle increases. If you remember from nervous system, our bronchioles are under the nervous system control, and they can constrict or dilate depending on if our lungs need more or less oxygen and air going through them. So the respiratory zone then begins where the terminal bronchioles end. So our terminal bronchioles are our last piece of our conducting zone structures. Our terminal bronchioles will end or feed into respiratory bronchioles, and these will be the start of your respiratory zone structures. So the respiratory bronchioles lead into alveolar ducts, and finally into alveolar sacs, which will contain clusters of alveoli, which is where gas exchange occurs. And when I mean gas exchange between the air and your bloodstream. So oxygen will go from the air you breathe into the bloodstream, and carbon dioxide will go from the bloodstream into the air to be exhaled. You have about 300 million alveoli making up most of the lung volume. And here we have the terminal bronchiole, which is the last of the conducting zone structures. And then we have respiratory bronchioles leading into the alveolar ducts, and then ending into the kind of these clusters of alveoli called the alveolar sacs, where gas exchange occurs. Here's another look at the respiratory bronchioles ending in the alveolar duct and alveolar sacs with the alveoli. You'll see little alveolar pores, which help to make up some of that respiratory membrane that we'll talk about. So the respiratory membrane itself is the blood-air barrier that consists of alveolar and capillary walls. So as we look at this picture, we have a membrane between the wall of the alveoli and the capillaries that are completely touching it. And this membrane is very thin. It allows gas exchange across the membrane by simple diffusion because it's incredibly thin, 0.5 micrometers. That's extremely thin. The alveolar wall consists of a single layer of squamous epithelium. This is type 1 alveolar cells, and scattered cuboidal type 2 alveolar cells. Type 2 alveolar cells are the cuboidal in shape, and they will be what secrete a liquid called surfactant, which keep your alveoli from collapsing. So your alveoli are like little balloons that naturally want to collapse on themselves, but this surfactant provides surface tension and it keeps them open. And surfactant is produced by type 2 alveolar cells, and type 1 alveolar cells help to make up the respiratory membrane because they're a single layer of the squamous epithelium. So this is what makes up that respiratory membrane. Other significant features of alveoli are shown there. We have some macrophages to keep everything clean and sterile. Alveolar pores, which can just connect adjacent alveoli together. So here's again a look at the terminal bronchiole, which is the end of our conducting zone. From there, we turn into the respiratory zone, so respiratory bronchiole into the alveolar duct and then into the alveolus. And you can see here how the alveolus is surrounded by these capillaries because the capillaries will want to pick up oxygen from the air that you breathe in within the alveoli and also want to unload the carbon dioxide that they're bringing so that your body can get rid of CO2. Here's a look at a micrograph of the pulmonary capillary cast surrounding those alveoli, and this is a look at the respiratory membrane. So what I mean by that is you see an alveolus or an alveoli, which is like a balloon. You see the different type 2 alveolar cells secreting surfactant. You see macrophages, pores. You see the rest are the type 1 alveolar cells that help to make up the membrane. And then here itself is the membrane, the alveolar epithelium, the fused basement membrane, and then the capillary endothelium. And this is incredibly thin, less than 0.5 micrometers, so that by simple diffusion, oxygen and carbon dioxide, oxygen diffuses into the red blood cells and carbon dioxide diffuses into the alveoli. And then we'll end a little bit talking about lungs and pleura. Specifics about this section. I don't think I had too many on your lecture exam, but I include them because it's a great review for anatomy. So here is the gross anatomy of the lungs, the root, the costal surface, the apex, the base. The hilum is the area, entry and exit of all the blood vessels, bronchi, lymphatic vessels, and nerves. We have a left lung and a right lung and different lobes to each. And again, the left lung is smaller because it leaves space for the heart and it will fit nicely into a cardiac notch. So here's a look at the anatomical relationship to organs in the thoracic cavity, showing where they lie within the rib cage, and then showing how the heart kind of fits in just left to the sternum. Here's a look at the hilum. So the hilum is where all the blood vessels and primary bronchi will enter and exit the medial side of each lung. And here is a transverse section through the thorax viewed from above, showing the esophagus, the bronchi, and then the different blood vessels. You see the pulmonary trunk and the pulmonary arteries bringing deoxygenated blood in blue to the lungs, and then the pulmonary veins will return oxygenated blood back to the heart. Understanding that well, what the heart, which blood vessels go into the lungs and which blood vessels come back to the heart is important as well to understand, just review how oxygenated and deoxygenated blood gets to and from the lungs. Here is how we divide the lungs into different segments. If one segment is deceased, so if it's dying off, sometimes due to cystic fibrosis or lung cancer, it can be individually removed and it can grow back slightly, but not entirely. People can also donate parts of their lungs to family members who have a match. Lobulars are the smallest divisions. Lungs are mostly composed of those alveoli, and the rest consists of stroma, which is extra elastic tissue that makes your lungs really elastic and spongy. I love this picture because it actually shows how the trachea comes down, divides it into bronchi, and it just looks like branches of the tree, how these bronchioles completely branch into different segments, bringing air to all parts of the lung. This is where we describe and review blood supply and innervation. So it's really important to review this just to understand what pulmonary circulation is. Remember that pulmonary arteries deliver systemic venous blood that's deoxygenated to the lungs. So remember, your pulmonary trunk brings deoxygenated blood, separates into pulmonary arteries, and the pulmonary arteries bring this deoxygenated blood to the lungs to pick up oxygen. The pulmonary veins then, once they pick up oxygen, they carry that oxygenated blood back from your lungs back to the heart. There's a low pressure, high volume system. The lung capillary endothelium contains many enzymes that act on different substances in the blood. For example, angiotensin converting enzyme will activate different blood pressure hormones. Bronchial arteries provide oxygenated blood to lung tissue. So lung tissue themselves need oxygen to function. Innervation of the lungs, nerves enter through a pulmonary plexus. Remember that parasympathetic causes bronchoconstriction because during rest and digest, you don't need a lot of air entering your lungs, whereas sympathetic fibers produce bronchodilation because when you're under a very high stress situation, you need a lot of air and oxygen flowing into your lungs. The pleura then is a thin double-layered membrane that divides the thoracic cavity into two pleural compartments and the mediastinum. The parietal pleura is the membrane on the thoracic wall, and the visceral pleura is the membrane on the external lung surface. There's a slit between the two called the pleural cavity, and that's filled with pleural fluid that just helps to provide lubrication and surface tension to help assist when your lungs expand and recoil and go back to length. Pleurisy is an inflammation of the pleura. We talked about this in one of our case study discussions, or was that a different class? Sorry, I can't remember. If your pleura are inflamed, they can become rough, resulting in friction and a stabbing pain with each breath. The pleura may produce excessive amounts of fluid, which could exert pressure on the lungs, hindering breathing. Other fluids that may accumulate in the pleural cavity is blood or blood filtrate, and pleural effusion is when fluid accumulates in that pleural cavity. So I'll stop there with part one tonight, or tonight in class, we'll do parts two, which will be about the same length. So I'll try to keep it short and sweet. Thanks for listening, guys. Keep up the great work and take care.